timeliness. Is that okay, Mark?
Yep, absolutely. I'm going to start recording right now.
Okay. All right, good morning. April case reviews. Have a couple good cases that I think will be highlighting some of the points that we want to do as best as we can, as always. So, as always, this is HIPAA information or information that's private and should not be shared. Any distribution, copying, or disclosure to others is strictly prohibited. And on with case one. So case one is of a 48-year-old male. The information provided was that it was a possible cardiac arrest at a local medical clinic of an employee who was working on a ladder. The patient's chief complaint upon arrival was unresponsiveness, and as mentioned, they were dispatched to a cardiac arrest, not breathing. PPE usage was a mask, gloves, and eye protection, and they found the patient to be unresponsive. Initial providers on scene were fire. The patient's airway was open, but he wasn't protecting. He actually did have a pulse, but he was not breathing adequately on his own, and that there was bleeding noted from his ears. I put in here a half a liter to a liter of blood coming from his ears by one of the crew's documentation. So sounds like bleeding and potentially decent amount of bleeding coming from his ears. 3 minutes into patient contact, the first set of vital signs were obtained. His heart rate was not taken, but his blood pressure was noted to be 120/69, respiratory rate of 12, GCS of 3, and SATs of 97%. Limited amount of information was available from this patient as he was unable to provide it, and not many people there knew him to provide it. In the story that EMS was given was that he was working on an electrical system while on a ladder approximately 20 feet up. He had an unwitnessed fall versus witnessed. One provider had documented that the witnesses had heard a thud. Another one had documented that they saw the patient fall onto his head onto a concrete surface. And when they came on scene, the patient was surrounded with a few physicians and a couple other medical staff. So this was early morning, 8:19. Spinal precautions were taken immediately. Vital signs were obtained. The patient's airway was secured with an eye gel and ventilated with a bag valve mask. And just a reminder to keep yourself on mute as you're logging in, unless you have something to ask. He was placed on a 4-lead and a physical exam was conducted. So the patient was evaluated, noted to have an injury to his 5th digit, concern for electrical burn injury to that digit. Pupils were fixed and dilated. 4 minutes into the second provider, the transporting provider arrival, he was given 160 milligrams for ketamine as they moved forward with intubation or RSI. At 5 minutes, I believe that an IV was already established. So at 5 minutes, a second IV was established. And at 6 minutes, he received 120 milligrams of succinylcholine. A full set of vital signs were obtained at 7 minutes, which noted tachycardia rate of 120. Blood pressure now is 100/54, respiratory rate of 16, GCS of 3, and SATs of 98%. He was actually, what I should mention is that the 4-minute mark is that when transport was initiated by the second arriving crew, so not a very long scene time for the transporting team. He was made a full trauma, and there was marked difficulty in obtaining or placing a endotracheal tube. So the first attempt, they suctioned beforehand. They're unable to get an ET tube. They did use video laryngoscopy and bougie. They were unable to visualize the cords, so they removed the ET tube blade or the laryngoscope blade, and an eye gel was replaced. He was suctioned. A second attempt at intubation was made That was also unsuccessful. I believe it was difficulty with visualization again. So the iGel was replaced. He was bagged up. At 17 minutes, a DL temp was made. They documented that they felt that this ET tube was adequately placed. Unfortunately, though, they were unable to get entitled tracing, so they pulled the tube. The third set of vital signs were obtained at that point: heart rate of 128, blood pressure of 96/71, respiratory rate of 13, SATs of 98%, and GCS remained 3. iGel was replaced, and he arrived to the hospital in 19 minutes. They did document that they had difficulty in communicating with their radio, so they had to use a Pulsera, and they had mentioned something along the complexities of even doing the Pulsera. As you can tell, after they arrived, they immediately left and spent most of their time trying to secure an airway, so trying to complete the Pulsera was definitely challenging. So in review of this case, just the pre-hospital components of it, I thought that it was clear that this was a hectic scene at a doctor's office, many people on scene. They, upon arrival, expedited care, recognizing that the patient was gravely ill and a full trauma. So spending as little amount of scene time as possible to get him to definitive care was made. They documented any issues they had with the scene and with his airway securement. They did a rapid primary and secondary survey, and they initiated spinal precautions in their documentation immediately, as well as airway management. Serial vital signs were obtained, and there was 2 peripheral IVs established in the documentation between the 2 teams. Where in reviewing this that I feel that we could improve is that they got a set of vital signs early on with this patient with the first arriving crew, and then they didn't get another set of vital signs prior to RSI. Here you can see that at 8:19 is the first arriving crew, and the next set of vital signs are obtained. What's that? So about 12 minutes, I believe, after first contact. And it proves an important, not just in this case, but in all cases, is that right prior to you RSIing somebody, you need to ensure that your patient is hemodynamically stable, and if not, to try to improve their hemodynamics prior to moving forward with paralytics and intubation, as they can have a precipitous decline or even arrest with the procedure. In addition, the documentation for the ET tubes were all documented appropriately in the chart, but each iGel replacement wasn't. So there was 3 intubation attempts and 1 iGel placement, which there were more airway attempts and completions that were missed in our documentation for accuracy. They gave the patient RSI meds early on, but it took, let's see here, so at 4 minutes in, but approximately 15 minutes later, they are still trying to secure an airway. So be cognizant about the time from when you've provided induction and paralytics to determine if you do need to redose that patient. That time frame would be a high consideration for redosing if necessary, if the patient has any intact airway, gag reflex, or tone. And then the first arriving crew documented an end-tidal CO2 throughout the entire encounter, except for the 3rd attempt for intubation. The transporting crew did not, so make sure that we are documenting our end-tidal CO2 even if the other agency is able to obtain it. And then this question to bleeding, up to a liter out of his ears at worst case scenario. There's not a lot to necessarily do. I wouldn't say that you would want to pack his ears or anything like that, but make sure that it's in your documentation if the bleeding was that substantial. Both treating crews should have that in their documentation. And then goals of care with a closed head injury, which is going to be part of the learning part of this case. And then with the concern for possible electrocution, 12 lead besides just a 4 lead would be better, given the patient's altered mental status, or at least what presumably was a prolonged syncopal episode. Yes, Dr. Whitwer says, do not pack the ears. I completely agree. So in the emergency room, he was noted to be tachycardic and hypotensive, 76/48. He had a respiratory rate of 20. He was statting 95%. And the additional information provided was that he was actually electrocuted at what they presumed to be at 270 volts while he was working on the electrical components at the clinic. He was resuscitated in efforts to get his pressure up with both IV fluids, push dose epi, and then he started on a norepi drip. He also received blood and a central line to administer his pressors and his blood. He was intubated with video laryngoscopy on the first attempt. Chest x-ray showed that he had a substantial left greater than right hemopneumothorax with medial sternal shift, so a chest tube was placed. And his imaging was pretty profound. He had an unstable thoracic 9 fracture with narrowing to the spinal cord or spinal canal. He had bilateral rib fractures. He had a scapular fracture, but besides his concerning spine injury, he also had a pretty devastating skull and intracranial bleeding. So he had multiple skull-based fractures, temporal and parietal fracture. He had a left subdural hematoma that extended from his frontal to occipital with a 9.5 millimeter midline shift. He had intracranial hemorrhages and subarachnoid hemorrhage. I have an image. So this is his. Hold on a second. All right. So the demonstration is to pay particular attention over the patient's left part of his brain where he had a substantial subdural. You can also identify white in the brain is going to be representative of bleeding, as well as his subarachnoid, and then his midline shift. He was, based off of that CT, he was given hypertonic saline and neurosurgery was consulted. They had reviewed his images and declared that he was non-operative and had a devastating intracranial injuries. So labs were significant that he already had an elevated CK of a little over 2,000. His lactate was 7.9. And despite the airway issues pre-hospitally, his pH was not that low. It was 7.3 with a PCO2 of 22. So maybe a little bit of hyperventilating. He was admitted to the ICU, and after discussion with his wife and the rest of his family, they elected to make him an organ donor, and he underwent a brain death exam on the same day of his presentation and organ procurement. Any questions, comments, thoughts before we move into the learning points?
I just want to underline that this was a really good job taking care of a really sick patient in a really difficult scene.
Yeah.
This is super hard and really well managed.
Yeah, that absolutely. It's what I didn't probably put it too much in. That was my major focus on the review for this case was that this patient had so many medical conditions, both trauma and medical, that were contributing to his presentation, and they did an excellent job of trying to manage all of them. The only thing I think I would probably say is that if you can bag them and you can't intubate them, if you can ventilate them through an IGL and you can't intubate them, I probably would have stopped after the second time of intubation. All right. So just to reiterate, I know that we've talked about these closed head injury goals of care or intracranial bleeding goals of care in previous discussions and lectures, but just it's always a great reminder to hit those points, especially when we recognize that our patient likely has pretty severe injuries. So ABCs recognizing that these patients, when they have a traumatic brain injury, suspicion for intracranial bleeding, if they are unresponsive, that they are likely not protecting their airway. And so consideration for airway protection would be highest in your kind of algorithm, if you think about it. And then managing making sure they have a pulse and managing their pressure, more so in the hospital setting for us, in regards to controlling severely elevated blood pressures. But in the pre-hospital setting, it applies as well as for the hypotension setting or hypotensive issues. So getting a rapid survey structured so that you're not focused too much on the most obvious injuries and recognizing any additional injuries, performing an excellent neurological exam. So that would be like your AVPU, your GCS, your pupillary exam, your CMS or PMS, depending on what terms you use. So checking a motor sensation. So we have a baseline, and also so that we can judge that on subsequent checks to see if there's been improvement or decline. And then other than the primary injury, which is the injury they sustained that we cannot reverse, is to avoid any secondary injuries. And those are the ones that we focus on in the pre-hospital and in the hospital setting, which is going to be hypotension, hypoxia, hyper or hypocarbia, and worsening intracranial pressures. What was I going to tell you? So hypercarbia, it can lead to vasodilation in the intracranial in the brain, which can facilitate worsening intracranial pressure. Maintaining a blood pressure allows for us to ensure that the cerebral brain blood flow is adequate. And one of the formulas that we use in the hospital setting, which we don't have a surrogate that I'm aware of for intracranial pressure, is a cerebral perfusion pressure, which is calculated by MAP minus intracranial pressure. And our goals are going to be anywhere from 50 to 70 millimeters of mercury, but that's more of like a bolt placed, and we monitor ICPs in the hospital setting. More things to go along with managing secondary injuries in the hospital setting would be avoiding or reversing anticoagulation so that we try to limit the amount of bleeding that the patient has. Prophylaxis would be giving them antibiotics if we think that there's an open fracture to try to prevent infection, and then potentially seizure management prophylaxis so that we reduce the amount of insult to the brain if they should start seizing as well. Depending on their condition, a lot of these patients don't necessarily undergo surgery, even if they aren't critical. But when surgery is indicated, they may undergo a craniotomy, a decompressive craniectomy, or a burr hole, which is literally a bedside drill that drills the skull, circular portion of the skull off to decrease the amount of intracranial pressure and alleviate the pressure in the brain. And then this image here on the right-hand side talks about the secondary injuries that we are looking to avoid. So mentions a little bit more extensive than the list that I have here. So you can look it over if you'd like. And then it was a good reminder for me to go through electrical injuries and just kind of review some things that you don't think about as often because we don't deal with electrical injuries every day. So electricity is the movement of electrons down a gradient, usually from high to low, or typically high to low. Current is expressed in the units of amperes, and it's a total amount of electrons moving down a gradient per unit of time. There is AC and DC circuits. AC circuits are represented here in this picture in the upper right-hand corner. So moving towards a positive and negative current, alternating current, and it's usually lower voltage. And then DC currents is represented here in this red line on this voltage by time, and that's a direct current, and it represents continued current, no oscillation in voltage. So we usually see DC with batteries, cars, computers, and then AC with lower voltage items such as household items. But you can see both AC and DC with high voltage systems as well. And then voltage is the potential difference between top and bottom of the gradient, and resistance is the obstruction of electrical flow by a material. We usually refer to resistance in the setting of the medical field as the resistance that the body leads to impeding flow. So skin is pretty good at resisting unless it's there's a cut or a break or laceration or it's wet. So the resistance decreases when it's not a dry skin surface. The parts of the body that is the least resistance to electrical current is going to be the nerve tissue and the blood and vascular areas. So those are going to be areas more susceptible to electrocution if the electrical conduction is able to be transmitted past the skin. And then another term used is let go threshold, which is the current required to prevent release of an electrical source after it's been made in contact with the hand. So the let go threshold is going to be lower for kids that won't at 3 to 5 milliamps they're not able to let go, but for adults it's up to 6 to 10 milliamps, which makes sense, and given the I guess strength or the muscle mass for the kids and adults. And then some severity factors for electrocution is going to be high voltage. You can still have a higher severity if you have a low voltage connection and you're not able to let go, or tetany. So if you're exposed to a low voltage over a longer period of time. AC, so AC can be problematic because if held on to an item long enough, it can have a propensity for a patient to go into ventricular fibrillation at lower amperes than direct current. And depending on the type of tissue that comes in contact with the electrical source for severity. There are 4 types of electrical injuries. They include flash, which are going to be like your arc burns, and they're superficial burns. There's flame, which is when the arc burns ignite the clothing, and it may or may not allow for conduction of the current through the skin. Lightning is your 3rd type of electrical injury, and it's usually short and high voltage. And then the 4th one would be true electrical injury, and that would be if the contact goes through the past the skin into the deeper tissues of the patient. So usually what happens with electrical injuries is it's usually going to be a thermal injury, superficial, but it could also lead to a necrosis of either the vessels because of the likelihood for decreased resistance, and also can lead to osteonecrosis. The electrophysical damage would potentially be leading to the patient to develop arrhythmias. Those arrhythmias can be AV blocks, bundle branch blocks, AFib, ventricular arrhythmias, and some of them can also develop STEMIs. Of the stuff that I was able to find for this, that usually these patients that do have evidence of a STEMI have clean coronaries. They believe it's the vasospasm that's leading them to have evidence of STEMI on 12 lead. They can also, the other injuries sustained from electrical injuries can be traumatic from the fall that they sustain, usually backwards from a height, or metabolic from muscle breakdown, rhabdo, renal failure along those lines, and potentially even compartment syndrome. So the image on the right-hand side shows cutaneous burns from a high voltage contact. The burns don't look very substantial, but if you see something that you see a patient that has underwent a high voltage contact, that it can be deceiving the cutaneous findings, as they can actually have much more substantial injuries below the skin. And then the recommendations are that if the patient has an arrhythmia, assuming that you suspect it, syncope, complaining of chest pain, or unresponsive, they should get a 12 lead and monitored on telemetry. Pre-hospital management is obviously to make sure that the scene is safe, that you don't want to come into contact with the patient if there's a live wire. So ensuring, obviously, this is your guys' forte, that the electrical company has cut power to that, or that the the circuit breaker has been shut off. Performing ACLS if the patient indicates it. Considering C-spine precautions, especially if there's trauma or if the patient is unable to communicate with you. IV fluids if they're hypotensive. Cardiac monitoring or 12 lead. And trauma versus a burn center if they're not the same place. If you have both a trauma and burn in a electrocuted patient, we would say to err on trauma and go to trauma first, and especially in our system where you would be bypassing trauma to go to a burn center if you think you have pretty substantial trauma from the injury. And then hospital management is very similar. We do a couple other things too, resuscitation. IV fluid resuscitation isn't guided by Parkland formula. It's guided off of urine output. So we're monitoring that closely, looking for signs of kidney breakdown or acute kidney injury from rhabdomyolysis and muscle breakdown, as well as cardiac monitoring and pain management, as you guys would be as well. All right. So going into our trauma protocol for Clark County, we want to rapidly evaluate these patients and determine if they need to be sent to a trauma center. Remember that patients age 15 and older can go to Peace Health, and that you don't have to go straight over to Randall's if they are 15 to 18 years of age. Direct communication with medical control to provide the following triage information or through Pulsera. So reminding everyone about our trauma activation criteria. So this patient with a 20-foot fall, and I would say 20-foot fall in addition to paramedic judgment would meet his criteria, and then his need for intubation as well would make him if he wasn't already, a full trauma. All right. Anybody have any comments, thoughts before moving on to the next case? So case 2 is of a 19-year-old male who we were dispatched to a cabinetry shop for an extremity injury. The dispatch information was for a hemorrhage. PPE usage was at the highest level. He was alert, his airway was open, he was protecting, his pulse was present, and a tourniquet was placed on his forearm due to bleeding. Vital signs were obtained prior to arrival by a first responding agency. Heart rate of 130, blood pressure 140 by palp, and respiratory rate was not obtained. He weighed approximately 68 kilos, and his past medical history included asthma. The story provided was that he worked at this cabinetry shop and that he works on a saw that's operated by a foot pedal. He was standing on a stool when he lost his balance. He hit the pedal and landed forearm first onto the saw blade. So the first crew arrived at 9:45 in the morning. At 10 o'clock, the transporting agency arrived and they initiated transport within 3 minutes of their arrival. They found that this patient had amputation below the left elbow, and this was the day where we had our snowstorm a couple weeks ago. So there was really poor weather in addition to in addition to the complexity of his care, which contributed to the decision to go to Peace Health. He had a 4 lead obtained. It doesn't show much of consequence, but there's some artifact. He's not tachycardic, narrow complex. His second set of vital signs were obtained. He was tachycardic at 108, blood pressure 151/141, probably spurious or inaccurate given the closeness of this diastolic and systolic. Respiratory rate 18, GCS of 15, SATs of 100%, and he received, at that point, his first dose of ketamine. He did have 100 micrograms of fentanyl provided earlier, and they document that they wrapped his extremity and placed direct pressure, and then also had a tourniquet placed at 9:45. At 8 minutes, another set of vital signs. They put him into Pulsera as a modified trauma. At 13 minutes, another set of vital signs, pretty much the same, tachycardic, hypertensive. At 17, but I will mention that they added the end-tidal CO2 at that point. And at 17 minutes, he received his second dose of pain dosing for ketamine. At 18 minutes, another set of vital signs were obtained, still tachycardic, still hypertensive. SATs are 100%, and end-tidals 19. He received 8 milligrams of Zofran at 20 minutes, and at 23 minutes, another set of vital signs showing much of the same, and he arrived at 29 minutes to the hospital. I will say that they documented that they placed his arm in a trash can with snow, so a little bit unclear if it was just placed in a can with snow or in a trash bag with snow or whatnot. So good tourniquet placement, time documented, serial vital signs, aggressive pain management for our protocols, and bad, just that the amputation management clarification. Was this patient's hand or arm wrapped in plastic and then put into a bag of snow? Was it rinsed off? It sounds like it was probably a clean amputation. Was there dressing applied to the stump end? Stuff like that. And then we had heard about this case prior to doing any kind of review, and initially the discussion was that online medical control was contacted, but in the documentation, it looks like it was not obtained or was not initiated, and so that the decision to go to Peace Health was based off of just the weather reasons. So maybe touching base with online medical control to determine if in good weather that they should have gone to Peace Health or across the river. So the patient arrived to the emergency room. He received antibiotics for prophylaxis. His tetanus was updated. Pain control was continued. He had labs obtained, and he was tested for COVID for the transfer. They flushed his amputation with saline. They redressed it, and they left the tourniquet on, stating that they didn't feel like taking it off would be beneficial and could compromise the patient's reimplantation. And this was his non-dominant hand, if I didn't mention that earlier. The trauma surgeon had indicated that he had asked EMS to stay shortly after they arrived to help facilitate a quick transport to Emmanuel. The patient was in a little bit of respiratory distress with his history of asthma. He was also given bronchodilators, assuming for some wheezing, and transport was arranged to Emmanuel. Just for clarification for the docs on this call, it was a 34-minute from time of arrival to transport for this patient. So he did not have a prolonged time at Peace Health. As mentioned, that may not have been the case. And then once he arrived to Emmanuel, he underwent a left arm reimplantation with a vein graft. They noted that postoperatively he had poor perfusion. He had a lack of Doppler signal, and there was evidence of skin necrosis. A few days later, he was brought back to the operating room, and he underwent an arm amputation revision with flap closure. He was discharged on the 16th with plans to follow up with arm dynamics for a prosthesis for his arm stump. So As a reminder, severed body part management, wrap it in moistened gauze with either normal saline or lactated ringers, place in a bag and place in a second bag or a container, doesn't have to be a bag, with ice and water, but it should not be directly on it. And then if it's a partial amputation, we should be splinting for pain, and it can also lead to improved perfusion potentially. So our protocols say the same, but that's the spoiler alert, but it says treat hemorrhage as expected with our hemorrhage control and universal patient care as well. And if there's a stump, we want to cover with a sterile dressing, saturate with sterile saline, cover with a dry dressing. If it's a severed part, rinse it with sterile saline to remove any debris, wrap the part with moistened gauze, place in an airtight bag, and place bag in ice water. And then partial amputation is a sterile dressing, saturate with sterile saline, cover with a dry dressing, and splint in anatomical position, and treat pain. The other point too is that this instance brought a lot of discussion to what we should be doing in the pre-hospital setting. And we've come to the agreement that if you have an amputation, that you should contact online medical control to determine if the patient should come directly to Peace Health or if they should go to a manual for reimplantation, but digits don't usually get reimplanted. So these are for amputated limbs. The question from Dr. Whitwer was, were there pain scales to follow the pain? I don't believe there was, but I can't speak with confidence that that was, I'm assuming you're saying in regards to pre-hospital documentation, Dr. Whitwer?
Yes, I'm just wondering, I'm sorry, if I cut my arm off, I'd like to have a little bit more than 100 milligrams of fentanyl ultimately, and 50 of ketamine. Now, if he was having really good control of pain, then that's one thing. It looks like his heart rate slowed down a bit. So I would say that's, but in that total of 29 minutes with the patient, he got 100 milligrams of fentanyl at the beginning. I would think we could probably have dosed him with fentanyl if he was having a lot of pain. His blood pressure is up, which kind of means to me like he's having some pain. Heart rate is what, 111, 107, whatever. But at any rate, I'm just for pain. This is a hard situation. I think this is very well managed. I've just say, hey, you guys are always wanting to give something for pain. This would be a good time to give another dose of fentanyl somewhere along the line here.
Yeah, that's a good point. And I think that I didn't put that, but I think I don't know if the crews felt that they were limited, but they definitely redosed multiple times. But I agree that the fentanyl could have been probably been more beneficial since the ketamine doses were only 25 as our protocol indicates. Yeah.
And then it's really for augmentation of the fentanyl at that point. So the fentanyl is going to be, I mean, the antidote to pain medication is pain usually. And so somewhere along the line, a little bit more fentanyl would have been nice. But no, I think this is well managed. It's a good example. I know we always want to rush these arm amputations to a manual, but frankly, most of them they don't get much luck out of reimplanting an arm.
Yeah, and especially a clean cut like this, guys. Granted, displays that they likely may not get reimplanted successfully. And what I hope that I mentioned in both these cases is the transporting Both these trauma cases, the transporting crews did not waste any time on scene. They expedited care easily within 10 minutes of arrival. So kudos to recognizing the definitive care need for these patients and getting them going there.
And from both of these cases would have been full traumas just based on either physiologic or anatomic criteria.
Yeah.
They're step 1 and step 2 cases, so they're an automatic.
Yes, and I was just gonna say, I think I may have glossed over this one, but amputation at proximal to the wrist and ankle would have had this patient meet the criteria as well.
Right.
All right, so case 3, unless we have any other discussion for case 2. All right, so case 3 was a 30-year-old female. They were dispatched to an unconscious party. PPE usage was appropriate. The patient was awake, her airway was open, and she was protecting. They noticed she was hyperventilating and that her pulse was present, and there was no signs of active bleeding. Vital signs were obtained prior to arrival by first responding agency, noted to have a heart rate of 140, no blood pressure was taken, her respiratory rate is 23, and her weight is a little bit bigger than normal, average. And past medical history included iron deficiency anemia, and that she had a remote history of heroin abuse and she was allergic to penicillin. They had actually arrived to a local business, and the patient was an employee there, had reported that she wasn't feeling well and that she was cold all over and had a headache. They noted that she was shaking. The vital signs, as mentioned, were prior to arrival. This again was another early morning call. 5 minutes into this call, they obtained a SAT of 97%. They noted that she had carpal pedal spasms, she was diaphoretic, and they attempted to coach her through her shaking and her breathing, but it felt like it was just making her more agitated and anxious. They indicated in their documentation that they thought she was withdrawing, so they kind of pressured or grilled her a little bit more, and she had said that, no, I've been clean from heroin for the last 5 years. They placed an IV at 11 minutes, and at 12 minutes, they gave her 5 milligrams of IV droperidol. At 13 minutes, they documented a heart rate of 178, up from her heart rate of 140 prior to their arrival. Blood pressure of 137/62, respiratory rate of 20, and a GCS of 15. And they initiated transport at 14 minutes. At 16 minutes, they recessed her vital signs. Her heart rate has now decreased to 116. She's still borderline hypertensive at 139/86. Her respiratory rate is 8, and her GCS is 15. Her blood glucose at that time was 158 milligrams per deciliter. And at 20 minutes, they got her first 4 lead, which most of the time I don't even report 4 leads, because if we're doing these, we should be getting 12 leads. And given her tachycardia, I think that a 12 lead would have been indicated, but this is the only tracing that we have for this patient, which is not high quality and concerning, at least with the amplitude of the complexes. I'm not really sure what to make of it, and the rate of it as well. At 23 minutes, she had another set of vital signs obtained. Now she's still improving in her tachycardia. She's becoming a little hypotensive or soft blood pressures with 99/62, respirators of 18, GCS of 15, SATs are 100%. And of note in the documentation, they said that she was trying to make herself vomit prior to giving her droperidol. At 24 minutes, another set of vital signs show this continued soft blood pressures and low-grade tachycardia. At 28 minutes, they arrived to the receiving hospital. Oops. Dr. Mock, do you want me to just give my assessment, or did you want to say anything about the discussion?
So I can talk about it. I mean, they're good serial vital signs documented, and it seems like the description of the patient presentation is clear. And honestly, the biggest reason that I brought this case up is that we have droperidol in the protocols for agitated combative patients, but in the pre-hospital setting, we don't treat anxiety, period, and in no setting do we treat anxiety with droperidol. So if anxiety is a component of it, then we work through that. But this is droperidol is a really useful drug for the agitated patient, but this patient didn't seem to meet those criteria.
Thank you. So in the emergency room, it's documented that the patient had, I think it's mostly based off of pre-hospital handoff report, was that she was complaining of dizziness and a headache. They get her first set of vital signs and she continues to have these soft blood pressures of 93/55. Her heart rate now is under 100. She's afebrile and her respiratory rate is documented as 14, SATs of 97%. I'll mention this comment thing in after this. So they document that her history was limited by the level of sedation that she had, the level of sedation that they presumed was because of her pre-hospital management. Because she's so difficult to get a history or to engage, they end up having to pursue a CT of her head to rule out any life-threatening things. Her labs are unremarkable. They gave her some IV fluids because she couldn't take anything by mouth because of her somnolence. And then they document that at 3 hours after her arrival, she appeared to be back to her baseline, felt much better, and was discharged home with a diagnosis of vertigo and a prescription for meclizine. I think the other thing is like those tachycardias, the 140s, the 170s, that could have indicated that this patient may actually have had an arrhythmia. So a 12 lead would have been very helpful to help identify that that wasn't playing into this as well, especially because her diagnosis ended up being vertigo. So if that was truly related to an arrhythmia, that would have changed her diagnosis and her follow-up. So this case made me think about a few of the A's documented and A's considered maybe. So first A being anxiety. And I just, I ended up just taking definitions or dictionary definitions from for each of these conditions. So anxiety is the feeling of fear, dread, or uneasiness. And this picture is supposed to help give you guys a feeling of what that might look like. This picture is supposed to portray agitation, and it's an unpleasant state of extreme emotion. It's not, it's like, oh, it's so upset. Someone cut you off. There's maybe a little bit of road rage. Hopefully it hasn't gotten to the point where you've got agitated delirium, where this is an acute confusional state marked by intense paranoia, hallucinations, and violence towards objects or people. So I know that this crew had documented that she was anxious and agitated, but I think that as Dr. Mock had mentioned, that we need to be recognizing things as they are, as like anxiety and agitation doesn't mean excited or agitated delirium, unless it is. But I don't think that the way that this was documented was the case. So a reminder about droperidol, we have two indications. We have it for sedation of agitated patients, and these are agitated delirium patients, not just agitated extreme emotion, and as an antiemetic. So our protocol for nausea and vomiting is for droperidol to be given at a dose of 1.25 milligrams IV, IM, or IO. And if they're over the age of 65, a strong consideration for halving that dose to 0.625 milligrams would be indicated, especially because it does have quite a bit of a sedating effect on it, and it can lead to a much bigger and longer workup in the emergency room or even admission. And then our agitated patient, which is our severe agitation, excited delirium protocol, does indicate that droperidol can be given. So for our extreme patient that is of risk of danger to themselves or others, that's the patient who should be considered for droperidol, not our patient that is agitated but not a danger to themselves or other people. But if they are at the high end of the emotional state that we're worried about danger to anybody, then droperidol can be considered as well as Versed. Droperidol dosing would be 5 milligrams IM or 2.5 to 5 milligrams IV. So if this is given, it should be given only for the extreme state and potentially even half the dose with the option to give another 2.5. This can be repeated every 15 minutes up to 10 milligrams total. Haldol is another option for agitated patients that are in severe delirium. Anyone have any questions or concerns regarding case 3? Yeah, go ahead.
Go ahead. I'm sorry.
No, go ahead.
Just as a sort of a spoiler alert, I've asked that we pull all the uses of droperidol for review. And that should start. I haven't seen them yet. We asked for that starting from the beginning of the month. So just want to check to make sure that people are using droperidol appropriately. It's a great drug, but can be used very inappropriately.
Thank you. Does anyone else have anything else to add to this case for discussion? I want to bring up on the previous cases, Mark had mentioned in the chat that to clarify verbiage, we do not use modified versus full when entering patients into a trauma system. EMS provides trauma entry criteria, and Peace Health will determine the level of response, which is accurate. And then as a reminder, there's 3 categories that your trauma patients will be sorted into. It's going to be either trauma consult, which a physician will meet you at the bedside, the ED physician, modified trauma, and full trauma, which both modified and full, as we were all aware, brings the trauma services at bedside as well. Recently, there was an ask from EMS about why are we not getting a reception with full trauma activation or trauma at bedside, feeling a little bit frustrated. That individual's feeling a little bit frustrated about that situation. And the ED doctor, when they arrive, as soon as you arrive, they do, for all intents and purposes, many of the same initial evaluation and resuscitation as trauma. The difference is that obviously they are not able to take them to the operating room. So when these patients are brought in where there's concern, especially in this particular instance of intracranial bleeding from a fall, but not on thinners, that oftentimes these are non-operative, or these are not going to be intervened with by trauma services. If it is, it's going to be by neurosurgery, and we are as able to consult neurosurgery to have them evaluated and taken care of. So when you are met by an ER doctor, it is not a lesser form of care or reception to recognizing that you identified your patient as being sick. So case 4 is of a 65-year-old male. The patient was complaining of aphasia. EMS was dispatched to a possible stroke. PPE usage was appropriate and highest level. Primary surveys that this patient's awake, his airway was open, he's protecting, his pulse was present, there's no bleeding, and his skin findings were pink, warm, and dry. The first set of vital signs were greater than 10 minutes, so I don't add them if they're longer than 10 minutes from patient contact for the initial assessment, because it's not so much initial for me anymore. And that's how I would hope that you guys see it, is if it's longer than 10 minutes, it's not really initial. He was an average weight male. He had a past medical history of a stroke with left-sided deficits that also affected his fine motor skills. He had a history of hypertension, Alzheimer's, and depression. In that the history provided from this patient was assisted by his daughter, who doesn't live with him but was over at the time, that apparently he developed symptoms 15 minutes ago. He said he had some word finding difficulties, in that he's had multiple TIAs. I think that it was documented as 7 over the last year, and that since the onset of his symptoms have resolved. Another morning call at 3 minutes. I think that this is probably a formality because of documentation, because we should be documenting BFAST, and if the BFAST is positive, then it should include a LAMS. So at 3 minutes, they document that they did a LAMS. At 5 minutes, they document they did a BFAST and a 4-lead. 10 minutes, an IV was established. At 11 minutes, his glucose was checked. At 12 minutes, his first set of vital signs were obtained. He had a heart rate of 58, a blood pressure 144/59, MAP of 87, respiratory rate of 18, and a GCS of 15. They also documented an SpO2, which is indicated for anybody that you are assessing for a stroke alert or a TIA. And at 21 minutes, they initiated transport. Another set of vital signs were obtained at 24 minutes. Again, bradycardic, a little more hypertensive. At 155/75, respiratory of 18, GCS is unchanged, SATs are a little bit better than previously, and then they arrive at the hospital at 30 minutes. So in the pre-hospital assessment of this patient, great with getting a BFAST, less than normal. They document LAMS, they start an IV, they check a SAT, they check a blood glucose, they do serial vital signs, they put them on a 4-lead, which is you minimum have a 4-lead or 12-lead for our KPI criteria. For this patient, they spent 21 minutes on scene, and they did not activate him as a stroke alert. And that I'll say now, and then I'll say at the very end of this, is that if the patient's symptoms are within 24 hours of onset, regardless if the symptoms resolve, we still want them to be brought in as a possible stroke alert. In the emergency room, because he was not upgraded to because he did not come in as a possible stroke alert, he was seen by one of our PAs. He reported to her that he woke up with a headache, and he developed he woke with a headache, and then he developed this aphasia while he was taking a shower that resolved within 30 minutes, and that he currently had some generalized weakness. The physical exam documented showed that he had weakness with his left grip and weakness with his strength of his left lower extremity, which he reported was his baseline. The CTA was unremarkable for any dissection, large vessel occlusion, but because of his symptoms, an MRI was obtained, and this showed a subacute stroke of his right occipital lobe. Neurology was consulted, the ED doc was consulted as well, and they recommended admission for him, as well as full dose aspirin and Plavix. During his admission checklist, he was tested for COVID. He was also COVID positive, and despite setting up admission for him, he left against medical advice. So an occipital lobe lesion should usually manifest itself with visual changes. Unilateral, like this gentleman, I think he was right occipital lobe infarct, should affect with the opposite side. So contralateral left homonymous hemianopia, which would be a field loss of vision on the opposite side, represented by this picture that's showing left-sided homonymous hemianopia. And then if the occipital lesion is affecting both the right and left, it would lead to cortical blindness, so loss of vision. So for our EMS protocols, just a reminder that we're doing our BFAST, our LAMS. I noticed recently that, I don't know if you guys are doing this in real time or whatnot. We should be doing it in real time, because it indicates if the patient should be coming to Peace Health or Legacy, depending on if they're trying to request to go to Legacy. But we should be documenting, or we should be calculating a LAM score I've asked a couple crews that have brought in patients for a stroke alert and asked what their LAM score was, and they said they hadn't calculated it yet. So I don't know if that's just because we went to Peace Health and that you'll calculate it later, and we only really want to know about it if we're going to Salmon Creek. But just as a FYI, Pulsera is moving to be active for the entire stroke committee or stroke team. And Dr. Whitmer or Mark, correct me if I'm wrong. That means that in the near future, that interventional neurology is going to be also notified of our stroke alerts in the hospital, like once they get to the emergency room. So knowing a LAM score will be helpful to get that into Pulsera for them.
And that's, and despite what the reaction of the hospital is going to be, the orders, I think, are pretty clear. And I want everybody to do this the same way, which is if you do a B fast, you do a B fast first. If it's positive, you are mandated to do a LAM score. Now, and that should be reported on your Pulsera, or it should be reported on your, if you're going by a HERE system, if you're going to legacy with the stroke. Now, the caveat, of course, is that any high LAM score, 4 or 5, should go to Peace Health rather than to legacy, even if the patient requests legacy, because destination is, that's what LAMS is there to determine the appropriate destination.
That, and then for Peace Health, we're looking at having our neurointerventionalists aware of them early on so that we can eliminate any delay in intervention.
Right.
Yeah. So please calculate these and have them for us when you give your handoff report in the emergency rooms.
And Dr. Gabon and I are, and the rest of the team, we'll be preparing a little checkoff sheet that you could use as a, sort of a non-mnemonic to remember what to do. But for the KPI for strokes, a BFAST, a LAMS, a glucose, last known well, time on scene, because we'd like to see you out of there within 20 minutes, and a stroke alert. Those are absolute, and a 12 lead. We'd prefer a 12 lead, but a 4 lead will suffice. It'll fit the bill.
And I think that a point for everyone, other than like, hey, you're just gonna, for the 4 lead or the 12 lead, is that we want to determine if they are in an arrhythmia that would be thrombotic provoking, so like AFib. So that's one of the reasons that we're identifying what rhythm they're in, and we're asking for us to have that. It's not just a checklist that makes no difference. It helps us in determining what are the risks for this patient to have a clot.
Of course, the KPIs that are universal to all patients would be your vital signs, and as well as we consider SpO2 as a vital sign, and I'm considering a CO2 as a vital sign going forward as well.
And then I added this case because a lot of the reviews I'm doing for our stroke alerts or our concern for stroke that you guys are documenting in your primary or secondary survey, stroke or TIA, is we're getting dinged on them because either their symptoms resolve prior to arrival or they resolve with us and we're not bringing them in as a possible stroke alert. So a reminder that if it's within 24 hours, they have symptoms that would indicate with our stroke triage tool that this could be a stroke, please have them come as a stroke alert so that they can get the appropriate reception and identification, especially for time-sensitive issues.
TIA is not an appropriate pre-hospital diagnosis.
That is-
You can suspect it, but you can't prove it.
And this is a great example with even a case we had last night, where the patient had complained of dizziness and vision changes resolved, had gone to a local fire department. I believe the fire department initiated the transporting agency's arrival, and 20 minutes after the transporting agency arrived, the patient developed a facial droop. So another example of waxing and waning symptoms should still be high on your radar. All right. So in summary, thank you guys for all your attention. We're coming to an end. Electrocution has multiple potential risks. That could be the thermal burns, that could be the electrocardiac, electrophysiologic or electrocardiac issues. If the patient has chest pain, syncope, or is unable to provide a history, we should be monitoring their rhythm, although we should be monitoring the rhythm. Most often they will develop their non-perfusing rhythm immediately, but there's a potential that it could be a little bit delayed, and that you can see a STEMI as well, and that they likely will have fallen from their contact with electrical source, so high index of suspicion for trauma. As for amputations, we should be rinsing it off. We should be dressing it with moist dressing, putting it in a bag, and then potentially putting it into another container that has the ice or water, but not directly on the finger. Contact online medical control for any amputations to discuss if they should be coming to Peace Health or if they should be going across the river. And in general, finger amputations, toe amputations don't get reimplanted. The many faces of emotional distress is the picture up in the upper right. So anywhere from anxiety to agitation to agitated delirium, and recognizing that we can treat anxiety in a supportive measure, but we are not giving meds to treat anxiety in our protocols. And then TIAs are, as Dr. Whitwer mentioned, they are not a diagnosis, they're a suspicion. And if it's within a 24-hour onset of symptoms, these should be coming in as a possible stroke. My references, go ahead.
Yeah, good. I have medics are always asking me, how do I know this is agitated delirium? You know, agitated delirium is the extreme of the agitation sequence, and it's generally occasioned by either usually it's have an underlying behavioral health issue as well as an underlying drug history, and so they're generally a dual diagnosis. You can't make that, but to me, it's very simple, especially in the middle of the night when you're trying to get through the night, is that you have a patient who's extremely agitated, so agitated that generally speaking, law enforcement is present. They're totally uncooperative. They're extremely emotional, wide swings of emotions usually, but very aggressive. They do not like you to touch them. They do not like you to take vital signs. So you're having difficulty doing all of these things. When you do notice them, though, that they're hyper. They're tachycardic. They're tachypnic. They're generally their blood pressure is quite elevated. If you can actually get a blood pressure cuff on them, and most importantly, they're hot. They're hyperthermic. Those are your big warnings then. Plus, then they are so agitated that you cannot start an IV on them to treat them. Most of your drug agitated persons, you can talk them into a position where you can get an IV in them probably and treat them. But these people you cannot. So they're so agitated. The only way you can get medication into them is IM. And so those patients fit the category in my book, middle of the night, of being hyper, of being the agitated delirium, and they need to get the Haldol and or Versed, well, Haldol and Versed, or Droperidol and Versed IM.
The excellent description.
And that just note that these are patients that are at high risk of moving into cardiac arrest. So sedate them, and then as soon as possible, get them on full monitoring.
Thank you, Dr. Mocht, as well. That is all that I have for you guys. So if no one else has any other thoughts or questions, thank you for your attention.
Thank you.
Thanks.